maybe for pre-diabetes or just border diabetes, one might go for lifestyle changes alone, but mostly people like to prescribe metformin along with that. Start with typical small dose, 500 milligram twice a day, movement on to maybe up to max of 3 grams. So these arrows indicate, we will walk through this algorithm, but these two arrows indicate that lifestyle changes and metformin will continue. Other agents would come and might go, but lifestyle changes and metformin will continue till end. So, according to the new guidelines, we need to classify these patients according to their atherosclerotic cardiovascular diseases. Majority would not have any addition, so majority can be considered with just any agent, metformin. After metformin, you can use any agent. But those who have heart failure or those who have CKD, even the earliest form of CKD, little bit of microalbuminuria, little bit of elevation of creatinine. So those patients who have CKD and those patients who have heart failure, even diastolic dysfunction, even little bit of production of ejection fraction. So those patients, they should be considered for another group of medicine. I just showed you which medicine. And then those patients who have existing atherosclerotic cardiovascular disease, in early document in 2018, they said those who have existing atherosclerotic cardiovascular disease, that means they have angina, they have TIA, they have peripheral artery disease, they should be considered. But now they say anybody who is at the increased risk of atherosclerotic cardiovascular disease. Okay, so for these patients, for the patients, the majority of the patients who do not have additional comorbidities, we can consider DPP-4, SGLT2 inhibitors, sulfonylureas or TZD. If economy is the cost is the deciding force, these agents, sulfonylureas and TZDs, are quite cheap and quite effective. But I think our concern is always the weight and hypoglycemia, so DPP-4 inhibitors and SGLT2 in combination with metformin and lifestyle changes will be a great option. Now those who have heart failure or CKD, they should be considered for GLP-1 receptor agonists or SGLT2 inhibitors. Those who have heart failure CKD, I think first preference should go to SGLT2 inhibitors. If somebody cannot tolerate SGLT2 inhibitors, then we can consider GLP-1 receptor agonists. If somebody has atherosclerotic cardiovascular disease, first consideration should go to GLP-1 receptor agonists, and if somebody does not tolerate, and I would also say somebody cannot afford, I think then you should consider SGLT2 inhibitors. Both can be combined also. First SGLT2 inhibitors, later GLP-1, or first GLP-1 receptor agonist, then SGLT2. Both, if combined, will make a very, very good combination, particularly in the context of lowering glucose, low weight gain, and increased cardiovascular protection. So I think, but this would be like expensive. Then of course, because all these drugs, they use our body's own existing mechanism, so they tend to fail with time, whereas insulin is always effective. Then there will be time for basal insulin and more complex insulin regimens. And these are the combination metformin SGLT2 inhibitors. If you want to combine them, there is no problem. Green light means you can combine them without any issue at all. And TZD, when TZD is combined with injectable, when you start insulin, it is generally recommended that TZD should not be used, although off-label it is used. Sulfonylureas, when you start insulin, I think sulfonylureas are not needed. And when you start DPP-4 and when you start GLP-1 receptor agonists, then DPP-4 are not needed. I think I will actually not be able to go to the detail. I could elaborate on these also. Okay.